Well, the next speaker is Dr. M. Saravanan. Acute kidney injury, AKI, or acute renal failure, ARF, in adults is terrible and I dare say bearable because he or she is an adult. But when it affects children, it is simply terrible and horrible and unbearable. Here is Dr. M. Saravanan, consultant nephrologist, Apollo Hospital, Chennai, whose special focus is on pediatric renal replacement therapy, including complex renal transplantation in this age group. Over to you, sir.
I think my topic is different. I think you read it strongly. My topic is marginal donation in living renal transplantation, just for a correction. So thanks for the organizer. I proceed direct to my topic as a marginal donation in living renal transplantation. And this is the current scenario of renal transplantation in India. So only less than 1% of individuals only are getting renal transplantation in any year, even after getting like a modern with even we have modern sophisticated medicines, only 1% of people are getting transplantation in a year. This is very sad story. And among this, the donors are predominantly from the live and only 10% from the disease. So there are many reasons for this, very poor transplant numbers, poor socio-economic status, financial affordability, a lot of things are there. An important reason is one of the important reasons is severe shortage of organs. So in this situation, we need to accept marginal donors both from the deceased and from the living donors also. And this is a very common practice in our day-to-day thing. What is the criteria for living donation is the donor should be blood related and it should be of same or O blood group, and age should be less than 60 years with no comorbids. The donor should not have hypertension and diabetes and no major comorbids, and the donor should have a normal renal function and normal structure. So anything that deviates from this standard definition is called as marginal donors. There is no clear-cut definition is given in the nomenclature, in the literature, but other definitions include even women of childbearing age and minors are also included in the marginal donors. But there is no clear-cut definition for that, but we are having a clear-cut definition for an expanded criteria donor from the deceased. So basically we need to accept these kind of donors to expand our donor pool. But there are a lot of risk factors in expanding, in accepting this expanded criteria donor from the disease. They have an high chance of DGF, they have an high chance of primary non-graft function and high risk of graft failure. In spite of this risk, if the benefits overweigh the risk, if the annual mortality of the dialysis patient is higher than 20%, and the patient is going to do well on accepting this expanded criteria donors from the disease, we always accept this kind of donors. But generally, we choose this expanded criteria donors for a marginal recipients, that is elderly patients on dialysis and those not doing good on dialysis, having multiple vascular issues. So those patients, we always tend to accept this donor from the disease. But taking this kind of donors, there is no harm for the donors because donor is already died. But that is not case in your living donor, because this is a important lesson that we are learning from even from the first year of an undergraduate, this Hippocratic oath everyone will take, that first do not harm your patients. Whether you are going to do a benefit to the patient or not, please do not harm your patient. This is a Hippocratic oath everyone will take. So there are different nomenclatures given for this marginal donors. I think the apt nomenclature is given by Resi et al. Is a complex living donors. So who are the complex living donors? What are the things that we need to ponder before accepting such donors in our group? So we always see the risk in accepting such donors. Risk means for the donor, the future development of an end-stage renal disease or CKD. For the recipient, after accepting this marginal kidneys, what is the graft survival, what is the graft quality that we need to discuss. And I always take a proper informed video consent discussing about the risk in taking the kidneys. And what I feel, others also in the group feel, this should be compulsory. That is if you are accepting a marginal donor from the family, there should not be other possible living related standard criteria donors available in that particular family. That is must what I feel. And if we can accept this marginal living donors, if the recipient's quality is very poor on dialysis, so we can accept in those situations. So these are the complex living donors that we know, when the age is more than 60 years, diabetic, hypertension and renal stone, stone, transmission infection patients. These are the marginal living donors. Also, patients with persistent microhematuria and mild proteinuria and borderline GFR are considered as a marginal donor or complex living donors. So these are the three major guidelines that I am presenting in this presentation. Like everybody aware of these three important guidelines from BTS, British Transplant Society, and KDIGO, and European Best Practice Guidelines. So what is the risk in donation? Risk means in terms of recipients, in terms of graft survival. There is an online calculator is available, that is a KDPI, Kidney Donor Profile Index, based on the 10 parameters from the Kidney Donor Risk Index. Whenever the KDPI score is more than 80%, the graft survival definitely will be good. But see, this is a note for, this tool is only for a deceased donor organ. There is no tool for assessing the graft survival from the marginal living donation as of now. So what are the risks after donation in terms of the donors developing into a future CKD? Definitely the incidence of ESRD is high among the donors compared to well-selected non-donor controls. This is based on the recent studies from the United States and Norway, long-term follow-up studies. The incidence of ESRD was 8 times and 11 times higher respectively. But however, the absolute rates of ESRD were low in both studies. So, and this is the standard paper from Grams et al. From CKD Prognosis Consortium Group. So the arrow shows, this arrow shows the risk of ESRD developing over the period of 15 years after donation. So there is a risk varies from 3.5 to 4.8% after donation. This is among the 5 million US cohorts. This is for the standard living donors. Whereas there is no ad hoc long-term study has assessed the impact of each individual donor risk factors, that is complex living donors, and the overall risk of developing ESRD after donation. So based on this study, there are multiple people formed here an online tool to predict the risk of ESRD over the period of 15 years. This is easily available in an online from the QS Med calculator. So they used 10 parameters: age, sex, race, ethnicity, and GFR, BP, diabetes, proteinuria, and smoking history. Based on these 10 parameters, they have formulated an online tool to predict the ESRD risk for the donors after donation. When coming to the individual risk factors, and diabetes is very, very important. This is a kind of a need of an aware whether you're going to take a diabetic donor or not. I feel like it needs a separate forum or separate time need to be allotted for this discussion, whether you are going to take a diabetic kidney or not. So everybody in the forum agree diabetes, by 2030, India is expected to have the world's largest population of patients with diabetes, and nearly more than 10 crore of our population is going to suffer from diabetes. Even 1 in 2 adults may have undiagnosed diabetes. So if it grows in that phenomenal range, nearly 20 to 25 crores of our populations are suffering from diabetes. In that scenario, by 2030, are you going to reject all the diabetic donors? I left to your discretion whether what you are going to do and what other guidelines says. So even this KDIGO, BTS, British Transplant Society, and European Best Practice Services, they are not saying no, it is an absolute contraindication to take a diabetic donor. They say the donor selection of the diabetes should be individualized, that can be taken under exceptional circumstances. And even KDIGO says it allows the acceptance of diabetic donor to a very low risk, generally older diabetic patients. And this is very, very important paper published in last year. The OPTN has changed its policy, that is published in October 2022 in CJSN. They are giving a guideline to accept the diabetic donors if the age of the diabetic donor is more than 55 years, with more than 3 years of diabetes, with well-controlled status of the diabetic status, with non-requiring insulin and requirement of 1 or 2 oral hypoglycemic agents, with no other comorbids. The patient should not have diabetes, should not have obesity, and should not have end organ damage, they should not have no proteinuria, no retinopathy, and no cardiac involvement. These patients can be accepted as donors. This is a very well presented, it's a revised OPTN policy. And there are a lot of recent papers they're showing that diabetic donors, they do well even after transplantation. And this is an important paper published in last year in 2022, the RELIEVE study group, the renal and lung living donor evolutions. In this they found they didn't find any major risk of ESRD after donation from the diabetic donors compared to other US kidney donor populations. it's like, no, I left to your discretion, like whether you are going to take a diabetic kidney or not. And recent papers are coming and saying that like diabetic donors are no longer to be a contradictory to the renal transplant donation. And coming to hypertension, this is from the Amsterdam Forum group. And if a hypertension individual age more than 50 years with well controlled with one or two drugs with no end organ damage obviously we know no proteinuria, no retinopathy and no LDH on echo with no other cardiovascular risk factors, they can be accepted as a donors. And obesity, generally like no, we don't do obese donors when the BMI is more than 30 kg per meter square because they have an high chance of perioperative risk factors, they have a long warm ischemia time, they have a high chance of delayed graft function, and moreover they have an increased risk of ESRD and high chance of diabetic and obesity related glomerulopathy in the future. So we always advise for the obese donors to reduce their weight before donation and proceed for transplantation. And how about taking an elderly donor? Elderly donor means as per the definition, the criteria given is age more than 60 years or 60 to 69 years is one group, another more than 70 years in another group. We know when you take an elderly donor, there is a higher chance of post-operative complications and definitely they progress to ESRD and cardiovascular risk factors and mortality definitely would be higher among the elderly donors. And moreover, not on the donor perspective, from the recipient perspective, they get a poor quality kidney because of the low nephron mass. They would definitely would have a poor graft survival. But what is the GFR criteria given by the guidelines? So more than 90 ml per minute, it should be adjusted to the body surface area that can accepted as a standard criteria donors. Some guidelines says more than 80 ml per minute is the cutoff for the donation. But less than 60 ml per minute, we don't take because it is defined as a CKD, it should be deferred from donation. And this group, like 60 to 90 ml per minute per 1.73 meter square is called as marginal donor. That should be individualized based on the demographic and health profile in relation to the transplant program's acceptable risk threshold. As we know, as the age advances, the age-related decline in GFR is there, that can be accepted. This is a nomogram given in the British Transplant Society. You can easily download from that one. So as the age advances, the GFR drops. So for the men and the women, so beyond a point particular age, like more than 60 years of age, if GFR falls, that we can accept as a marginal donor. And how to calculate the GFR is given in KDIGO guidelines. I'll skip this one. And if there are any parenchymal, vascular or urological abnormalities or any asymmetry of kidney size on renal imaging, asymmetry means if the size of the kidney is more than 2 centimeter difference and the differential function is more than 10% difference on the DTPA, single kidney GFR should be assessed. But this should not preclude donation. The more severely affected kidney should be used for donation. And hematuria, if a patient donor is having a persistent microscopic hematuria, we can even take them as a donor. They should have a normal renal function. They should be having a normal BP. There should not be any history of stone or no hypercalciuria. Especially in the elderly, cystoscopy should be done and then should be proved to be of malignant free. And all of these patients should definitely undergo a renal biopsy with electron microscopy. If you find TBM, thin basement membrane disease, that can be accepted as a donors because thin basement membrane disease is only a pathological entity. There is no increased risk of ESRD in these patients even after donation. So all the guidelines say like thin basement membrane can be accepted as a donor, whereas there is a differential of opinion in lanthanide, that is subclinical or incidental IgA nephropathy and female carriers of Alport syndrome. So but generally most of the guidelines, they differ donation in these patients. But there is a kind of controversy in accepting an incidental IgA nephropathy patients. Most of the guidelines disfavor, but some of nephrologists in our forum also may differ with this view. And even one of the biggest transplant center in the Tokyo, they found in the Japanese living donor population, nearly 16.1% of the living donor allograft biopsies, they have an incidental IgA nephropathy. They became very silent after donation. So I left your discretion whether you are going to take an incidental IgA nephropathy or not. But coming to the female carriers of Alport syndrome, if the female carriers of an X-linked Alport syndrome definitely should exclude donation because they behave aggressively, the chance of an ESRD is very high. Whereas in the Alport recessive Alport carriers, it's a controversy. So the expert guidelines for the management of Alport syndrome, they favor donation because they say like, no, the autosomal recessive Alport carriers, they behave very silent. The chance of getting into ESRD is very low. But in other group, another paper published in 2012, they say like, no, the incidence of ESRD is very quite similar compared to an X-linked and to an autosomal recessive, so they disfavor donation. And proteinuria, definitely less than 30 milligram per day albumin excretion rate is an acceptable level of donation. As age advances, your proteinuria is also definitely would be increasing. So anything that proteinuria albumin excretion rate more than 30 to 100 milligram per day can be accepted if the donor is very elderly. And coming to the vascular anomalies, renal artery multiplicity up to 3 renal arteries and venous anomalies should not be a contraindication to a living kidney donation, and conclusions cannot be drawn for donors with 4 or more arteries and definitely should not be excluded from donation because it needs an eye surgical skills rather than to deny those kidneys actually. So a small accessory artery that supplies the upper pole, a minimal area, can be sacrificed, whereas an accessory artery that supplies the lower pole, because you should not sacrifice the spin, it should be saved because it's going to supply the proximal ureter also. But in case of complex venous anatomy, there is usually only one domain vein and the remaining veins can be tied off. And coming to the kidney stone, the old ARIC and the National Health and National Examiner surveys impressed that history of renal stone itself is an important risk factor for CKD and ESRD, but later multiple studies and meta-analysis disproved this one. They did not find any significant risk factor for ESRD. Hence, this is not included in the online risk tool. That is I already told in the previous slides. So when you are going to accept donation for the renal stones, if the patient is having a very small stone less than 1.5 centimeter, that can be easily removable during transplantation ex vivo, and there is no multiple stones and there is no history of recurrent stones, if there is no history of metabolic abnormalities, then we can accept donation from this renal stone patients. And defer donation if there is having an eye metabolic abnormalities and the risk of recurrence is very high, and cystoid or screw-weight stones should be excluded from donation, and the patients having a multiple stone should be excluded. When a younger age, less than 40 years, with a family history of kidney stones and frequent recurrent kidney stone, they have an high likelihood of risk of stone recurrence, so they should be avoided as a donors, whereas an older age with only single stone less than 1.5 centimeter with no prior history of stones can be accepted as a donor because they have a lower lifetime risk of stone recurrence. And coming to the transmissible infections, definitely HbA/Ag positive donors should not be donated to an HbV negative recipient with no protective immunity, but we can accept HbA/Ag positive donors with HbA/Ag positive patients and also HbA/Ag negative recipients with HbV protective immunity. HbA/Ag donors can be accepted. Core positive patients definitely we accept because the chance of transmission are very less. Hence, they can be donated. But before proceeding this HbA/Ag positive to HbA/Ag positive, informed consent is very mandatory, and the patient should undergo a post-transplant HbV prophylaxis. And coming to a HCV donors definitely can expand the organ pool with the availability of direct antivirals. They should complete their 12 weeks of an antiviral and should have a sustained virological remission before donation. And this is an important paper published a week before in current opinion organ transplantation. After acceptance of HCV positive patient, by 2021, nearly 93% were transplanted to HCV negative naive patients, and the proportion of weight-related patients willing to accept a deceased donor kidney from HCV positive has increased 20-fold. So from 2015 to 2022. So with the availability of direct antivirals, we should not reject an HCV positive patients. And regarding HIV, we are moving away from the era of a contradictory HIV transplant to accepting donors from HIV positive. So in 1984, NOTA actually prohibited HIV infected to donate, and later they revised the policy in 2013 to repeal this prohibition and authorize the OPTN to develop a standard for the use of these organs. And we have an initial positive experience from South Africa in 2020, where they accept HIV positive disease donors to the HIV positive kidney donors. They found a good graft survival in the 3 to 5 years period. So based on this initial experience, the first successful live transplant from the HIV positive donor to HIV positive recipient was done in Johns Hopkins Institute. Later, multiple centers in the US started doing an HIV positive donor transplantation, and they found a positive result, and they found a graft survival almost similar to an HIV negative donors. Based on this experience, now OPTN is revising their policy. I think by the next year they are going to release a revised policy in accepting HIV positive donors also. But what are the things to note? Both the donor and recipient should be on ART. They should have an undetectable viral load, and CD4 count should be more than 300, and donors should not have any opportunistic infections or should be treated for that. And TB, generally active TB we don't take. From the treated TB we can accept. For latent TB also can be accepted if they are ready to get a chemoprophylaxis after donation and after transplantation. Coming to that cancer, treated cancer definitely can donate if they are, after confirming that individual case factors are associated with a very low risk, less than 1% risk of both lifetime recurrence and disease transmission. And some of these cancers are definitely is an absolute contraindication to donation, but renal malignancy is no longer a contraindication, donation to be considered as per individual case-to-case basis. And this is an OPTN malignant subcommittee. So those who are having minimal to low to intermediate risk with less than 10% of transmission event, they can donate after informed consent with proper case-by-case discussion, whereas more than 10% transmission events should avoid donate. And even
Dr. Saravanan,
only 2 slides. Yeah. And even in renal malignancies, small well-differentiated cancer less than 4 centimeter with complexes can be accepted as a donor if the back table excision after donor nephrectomy is possible. And coming to the genetic kidney disease, whenever you are having a familial renal disease, that you are accepting donors from the family, they should undergo a mutation analysis. If they found to have the same mutation of the recipient, they should not donate. Whereas autosomal recessive mode of inheritance is usually not a contraindication for living kidney transplantation. And generally, women of childbearing age should not be excluded from donation. And coming to the last part of my slide, in our center, we are 10 nephrologists practicing nephrology, and we're doing a transplantation. Even in among our people, we have a multiple difference of opinion, and we don't reach a broad consensus also. But we have done transplant for even I have done a transplant for an oldest age that we have done as in 74 years. The grandfather donated to a granddaughter. I've seen him a couple of weeks before. This transplant was done in 2 years before, and the donor is having a creatinine of 1.2. It's no, I said there is no contraindication accepting such even such donors also. And even one of my colleagues has done a transplantation for an HIV positive donor, transplanted an HIV positive. In conclusion, complex living and marginal donor acceptancy is a great need of the hour because of shortage of donor organs. So we need to expand the donor pool, but it should be considered only after assessing all the possible risk factors for both the donor and the recipient. And what I feel, there should not be other possible standard criteria living donors in the family, then only we can accept this marginal living donors. And we should get proper informed video consent, that is very, very must. And we need to collect data for home information in our subcontinent so that we can expand this donor pool. And thank you. And this is a funny description of a nephrologist given in one of the dictionary. So a nephrologist is someone who does precision guesswork based on unreliable data provided by those of questionable knowledge. So we are the nephrologists, we don't want our patients to suffer. We are doing a precision work for the better livelihood of our transplant patients. Thank you.
Thank you so much, Dr.